In this session, we will be talking about assessing pain and taking a pain history. The presentation has been prepared by Dr. Anurag Agarwal. He is Vice President of UP chapter of National Association of Palliative Care for Ayush and Integrative Medicine. Why is it important to assess pain? Why should you use tools to evaluate pain? What are the components of the pain assessment process? How to optimize the pain assessment? Pain assessment in children and in patients with impaired communication. Pain evaluation tool which are practical for low resource settings, and pearls. So, there is a case, you are working in a small rural hospital when Parmanand, a 17-year-old male, is admitted after a motorcycle accident. He is awake, hemodynamically stable, and seems to have fractured his left leg. He is groaning. The surgeon tries to carry out a physical examination, but Parmanand resists. Do you need to assess Parmanand's pain? How would you do it? How should you act once you have assessed Parmanand's pain? Are the questions. Pain assessment tool. When to assess pain? On admission or a change in medical condition which occurs that may indicate the presence of a new pain, as in case of fracture. When verbal and or behavioral observations of pain are noted, and when a person or family states that they are having pain. A multimodal team approach is involved in pain assessment. The patient and family, they are there, health providers, doctors, nurse, social workers, psychologists, chaplain, volunteers, physiotherapists, and the community is also involved. So, assessment of pain is the first step in planning pain management. Pain assessment should be repeated to evaluate the efficacy of pain management, tailor the assessment tool to the patient's age, condition, type of pain, whether it is acute or chronic. Evaluate the patient's other symptoms, functional status, general clinical status, and parallel with the pain assessment. Pain assessment should occur at each clinical encounter, regular intervals after initiation of treatment, that is a suitable interval after pharmacologic and non-pharmacologic interventions, 15 to 30 minutes after parenteral drug therapy, and 1 hour after oral administration. Each new report of pain has to be considered. So, ask about the location of pain, the quality of pain, the intensity of pain, and the duration of pain. What is alleviating and what is aggravating, that is medicines, drugs, alcohol, herbals, movement, positioning, etc. Impact on patient's life, whether it is impacting the daily activities, work performance, social contacts, etc. Medication related side effects, if there are any. Ask and assess for other symptoms, may be nausea, vomiting, constipation, confusion, depression, and dyspnea. How to assess a patient's pain history? It may be termed in terms of PQRST. Now, P stands for whether the pain is provocating or palliating. That means, what provokes and what palliates this pain. Where were you doing when the pain started, what relieves it and what aggravates it. The quality or quantity, what does it feel like? Sharp, dull, burning, cutting or shooting. Region or radiation, where is the pain located and does the pain travel or radiate. Severity scale, how severe is the pain on the scale of 0 to 10. Timing of pain, when at what time did the pain start, how long it is there and how often it comes. We should record all these. And what is the +2? What have you tried to relieve the pain and has it worked? And how is the pain affecting the quality of your life? That is the mood, mobility, work, play, appetite, sleep. Allow sufficient time for the assessment. Use interpreter if language of communication is second language. Give the patient opportunity to use a rating scale or other tool appropriate for that population. Use pain indicators according to the following hierarchy of importance: patient self-report, pathological conditions or procedures known to be painful, pain related behaviors, grimacing, restlessness, vocalization, reports of pain by family members or caretakers, physiological measures or vital signs, reliance on behavioral or objective indicators of pain, that is vital signs only when no suitable alternative exists. So, self-report, what the patient is saying is the gold standard. We have to believe the patient. Observation, what people do. Self-report is not fully trusted or not available. In case, then observation is important. Physiological parameters may be there for infants and critical care. Visual analog scale, it ranges from no pain to worst pain. It may be a 10 centimeter long line, mark 0 at one end and 100 at the other end on the back side, and then we can grade it every 10 points from 0 to 10, where 10 is worst pain and 0 is no pain. So, verbal rating scale is also available. So, where mild pain is from 0 to 4, moderate pain stands from 5 to 7 and severe pain ranges between 8 to 10. So, categorical scale, here we use smileys and we can see that there is no pain, a little hurt is there, a little more hurt may be there, we can see even more hurt, a lot of hurt and the worst hurt is there. So, this can be used in case of children. Now, those who are not literate, in case of rural areas, even we can use the percentage of coin or ANA scale. The universal pain assessment tool is something like this, where 0 is no pain and 1 and 2 may mean mild pain, 3 and 4 moderate pain, 5 and 6 again moderate pain, 7, 8 and 9 are severe pain, and 10 is the worst possible pain. Pain phases scale, we can see no hurt, hurts a little bit, a bit more, hurts even more, hurts a whole lot, and it is the worst hurt possible. Communication of pain, locate the pain, where is it from? Patients can be requested to indicate the primary sites of pain by shading relevant areas on a figure of a human body. For example, in case of low backache, they can shade that where this pain is. This can indicate the direction of radiating or referred pain. That means, if a person is having pain over here and is stretching down to the lung, so this is made by the patient itself. Here we can see the pain map for the front side of the body and the back side of the body, and then we can ask whether it is burning, constant, radiating, and what is the score of the pain. So, in case of communication of the pain, we have to locate the pain. So, here we can see a land color scale which is used for children, that where do you have this pain, and they shade it, and the type of pain they shade the type of pain, that where it is how much. There could be web based diary measure, how much did the H's of pain hurts today. So, if the pain is varying on various day, it can be noted on the diary on different days. Factors influencing perception of pain. The patient is an expert about his or her body. His self-reported pain should be accepted as accurate. In communicating with patients, rely on the patient's self-report. It is affected by a variety of factors. Factors influencing a person's experience of pain may be positive versus negative expectations, mood, there may be cells of hopelessness, optimism, culturally acceptable levels of complaining, coping and adaptation abilities, and meaning attached to the experience of pain. Caregivers should not wait for the patient to report about pain, but actively and sensitively explore this with the patient. So, active listening is very important. Allow patients to describe their pain in their own words. Do not prompt, because that may be judgmental. Consider that patients may report their pain experience in socially acceptable words. When patients feel uncomfortable describing their pains, healthcare providers can suggest a sample of relevant descriptors. They can be written on cards also. So, those patients who are having barriers in communication, they can affect the pain assessment too. Hence, pre-verbal children may be such example, individuals of advanced age may be the other ones, those patients who are having dementia or patient with emotional or cognitive dysfunction, patient who do not speak the same language as the caregiver or care provider, and patient who are very seriously ill. In case of children, even newborns feel pain. Quest approach is used. Question the child if verbal and the parent or guardian in both verbal and non-verbal children. use pain rating scales if appropriate, evaluate behavior and psychological changes, secure the parents' involvement, take the cause of pain into account, and take action in evaluate the results. Assessing the behavioral signs of pain, FLACC pain scale, it is for less than 2 up to 5 years. The face expression can be noticed. Is there no expression, occasional grimace or frown, withdrawn, disinterested, or frequent to constant quivering chin, clenched jaw? Then position of legs, normal position or relaxed, uneasy, restless, tense, kicking or legs drawn up, activity, whether the patient is lying quietly in normal position, moves easily, is squirming, shifting back and forth, tense, or arched, rigid and jerking. Whether there is no cry, moans or whimpers, or occasional complaint is there, or crying steadily, screams or sobs, and frequent complaints are there. Consolability, content is relaxed, reassured by occasional touching, hugging or being talked to, or distractible, and difficult to console or comfort. So, we have to give the numbers and match the total score. How to use FLACC? In patients who are awake, observe for 1 to 5 minutes or longer, observe legs and body uncovered, reposition patient or observe activity, assess body for tenseness and tone, initiate consoling interventions if needed. In patients who are asleep, observe for 5 minutes or longer, observe the body and legs uncovered, if possible reposition the patient, touch the body and assess for tenseness and tone. Interpreting the FLACC score, each category is scored on a 0 to 2 scale, which results in a total score of 10. Relaxed and comfortable, if the patient is there, then the score would be 0. In case of 1 to 3, there may be mild discomfort. If the score is 4 to 6, there is moderate pain, and in case of 7 to 10 score, severe discomfort or pain may be there. Oucher scale is used for patients who are less than 3 years, and this is basically a poster where we find the expressions of the patients, and those children who do not know how to read, they can simply see the face and find out how much pain they are having, and those who can read, they can give you the numbers, and this can be adapted in your local community with the local faces. Pain assessment in older children over 6 years can also be used in adults unable to use numerical stage. So, here we have a verbal rating scale, where here we have no pain, and when we go higher, it is the most intense and unimaginable pain. The UN definition of older people may not apply for sub-Saharan Africa, where complex and multidimensional socio-cultural definitions exist: seniority, status, number of grandchildren, etc. It is challenging to assess pain among geriatric patients with multimorbidity, polypharmacy and dementia. Visual and hearing impairment may also be the obstacles in pain assessment of the aged people. Use behavior based proxies in non-communicative cases. In principle, for the geriatric patient, ask for the pain, and this is how we assess the pain of the aged. Pain assessment for cognitively impaired people. Self reports of pain are no less valid. Ask you, are you in pain? Believe the person's report of pain. May be able to use pain rating scale, so answer yes no questions about the pain. Allow time to rate pain. Ask more than once and in more than one way. Ask about the present pain. Pain assessment should be part of daily routine as it is the fifth vital sign. Tailor the assessment to the patient, example age, cognitive ability and literacy level. Aim to use validated pain assessment tools. This helps to standardize the process of assessment. And pain assessment is not an academic exercise. Assessment should be used planning management of pain. Once you have made an assessment, interpret it and carry out the relevant therapeutic intervention. From 0 to 10 scale, if it is less than 3, no change in therapy is typically necessary. If it is greater than 3, typically analgesic therapy should be administered or current regimen should be changed. Pain emergency typically intensify from 9 to 10 score out of 10, and analgesic therapy should be given immediately and intravenously if appropriate. Pulse 3. Interview the patient about which factors aggravate or relieve the pain. Can help to identify the etiology of pain. Pain worst at early morning hours, it could be inflammation. Pain constant and severe, is it a chronic pain disease? Pain decreases with movement, is it osteoarthritis? Pain worse on coughing or sneezing, is it radicular pain? Pain is alleviated with a cool pack, is it inflammation? And pain is alleviated with heat, is it a muscular pain? Pain descriptors help to differentiate the etiology of the pain and points to a therapeutic strategy. Burning, shooting, electrical. Think pain is of neuropathic origin. Dull, itching, drilling. Think this pain is nociceptive origin. Case study. You are working in a small rural hospital when permanent a 17-year-old male is admitted after a motorcycle accident. He is awake, hemodynamically stable and seems to have fractured his left leg. He is groaning. The surgeon tries to carry out a physical examination, but permanent resists. Do you need to assess permanent pain? How would you do it? How should you act once you have assessed permanent pain? Permanent seems to be in intense pain, and so it is imperative to control his pain as quickly as possible. Permanent is of an age that he can be verbalize his pain, therefore, ask him to assess the intensity of the pain. Use verbal descriptor scale or numerical pain scale. If there is no acute volume loss, initiate analgesia before further diagnostic procedures. When the pain is severe, management should be intravenous and opioid based. Using the body diagram in this acute situation is not at all necessary. Keep this scale in your pocket whenever you are visiting your patients to find out whether the patient has no pain, has mild pain, has moderate pain, severe pain, very severe pain and the worst pain. Thank you.